All right, welcome back, everyone. I know we're a few minutes behind. We had to take a little bit longer break, but we are back and energized for our next panel discussion. This time, we're going to bring it back into our nation, and we're going to discuss environmental racism in AMR. I'm going to turn it over to Dr. Robin Patel, who's going to be moderating the session. Dr. Patel.
Thank you so much. Our final panel today will look at the relationship between environmental racism and drug resistance, how the conditions of where we live, work, and play impact our health, specifically as it relates to antimicrobial resistant infections. It's my pleasure now to welcome our panelists, Dr. Roshanak Medipana, an associate professor at the University of Michigan School of Public Health, Dr. Maya Nadampally, an assistant professor at the Rollins School of Public Health at Emory University, Dr. Jacinda Abdul Mutakabir, an assistant professor at the Skaggs School of Pharmacy and Pharmaceutical Sciences at the University of California, San Diego, and finally, Dr. Jasmine Marcelin, an associate professor at the University of Nebraska Medical Center College of Medicine. We're excited to learn from all of you. And let me thank you in advance for speaking with us today. And please go ahead, Dr. Medipana.
So, hi, everyone. Thank you for having me. Today, I'll be talking about environmental racism and its impacts on health disparities. Slide. So, I'm not sure how familiar you are with the term environmental justice, but according to the EPA, environmental justice is defined as the fair treatment and meaningful involvement of all people, regardless of race, color, national origin, or income, with respect to the development, implementation, and enforcement of environmental laws, regulations, and policies. So to put that into perspective, in the United States in 2021, according to a social vulnerability report by the EPA, 42 million American homes suffered from energy poverty. So they did not have access to any form of either heat measures or cooling measures, making them vulnerable to intense heat and cold. More than 2 million Americans currently live without basic access to safe drinking water and sanitation, and about 11.9 million Americans, disproportionately people of color, are exposed to unhealthy air pollution levels. So while environmental justice encompasses a really large topic, I want to centralize the rest of this talk on housing. In particular, a large proportion of the housing stock in this country is now over 40 years old. And in much of the housing that we see across the country, we're seeing that homes are lacking basic infrastructure. So at the heart of it, where you live or your housing plays a huge role on how badly you are affected. Slide. So housing is a determinant of health. For those who are not familiar, when we're talking about social determinants of health, these are the conditions where people they're born, live, learn, work, play, worship, and age that could affect a wide range of health, functioning, and quality of life, outcomes, and risks. Housing is a multidimensional determinant of health as it encompasses multiple levels. So we talk about affordability, how much you can pay for your housing and how much money is left then for other things in your life. We talk about conditions, so the type of housing, what happens inside your housing, whether it's poor infrastructure or lack of roofing or even missing basic kitchen or washroom necessities. And then we talk about access. So this is beyond income or financial measures to also include discrimination folks face at the time of trying to attain or maintain their housing. Slide, please. And why this is important? Well, at the core unit, a housing that is unaffordable, inaccessible, and poor quality homes can have detrimental impacts on people's health. At the neighborhood level, we know that when this happens, it usually translates to greater disinvestment. So it's a signal for poorer infrastructure in the neighborhood, lack of resources in neighborhoods. And we know that in the United States, greater proportion of non-white racialized groups, particularly non-Hispanic Blacks and Hispanic Latinx populations, are more affected by this. And we know that the distributions of resources by city and or counties are not equitable, and that there are structural forces that have been created and that reinforce these neighborhood inequities. So for many years, we've been talking about where you live matters and how place-based research impacts health. But what we haven't really been talking about, it's the why. So it's not where you live, it's really why that we're trying to answer today. Next slide. So again, I'm not sure how familiar you are with this, but one of the structural policies that has been more widely studied, primarily due to the availability of data that allows us researchers to kind of study this, is the historical redlining practices. So just a bit of background. In 1934, as part of the New Deal by President Roosevelt, the Federal Housing Administration was intended to really make homeownership more accessible to the middle-class Americans by providing these low, long-term lasting mortgages. However, the FHA also instituted the practices of redlining, in which neighborhoods consisting largely of people of color were categorized as financial risk and excluded them from attaining mortgages. So by restricting access to affordable homeownership in these neighborhoods, including literally building walls, such policies constrained housing choice among people of color and contributed to this long-term disinvestment in urban communities. Slide. And this is an example of the Detroit Wall, which continues to exist today, that literally determined whether one neighborhood had access to housing, in particular mortgage insurance, and another neighborhood did not. And this wall continues to exist today. Slide. So on your right, yes, on your right, you'll see a map of an example of a historically redlined neighborhood in Brooklyn, New York. And so this is just to highlight how these maps were created, literally with red lines, where areas that are depicted as green were considered to be best or most prosperous for investment. Blue areas were defined as still desirable. Yellow areas were designated as definitely declining, and the reds were considered as hazardous. So as I mentioned, redlining did not necessarily cause segregation, as it was already there for folks to draw these lines along the lines, but it did further institutionalize neighborhood racial segregation. And it restricted access to home ownership for non-white racialized home buyers, who then were forced to look for other resources like land contracts, which were very precarious, where if folks missed their payments, even by a couple of hours, their entire equity in the home would be taken away from them. Slide. So these historic redlining practices have led to long-term disinvestment, and research has connected these neighborhoods with socioeconomic factors, including lower credit scores and higher disinvestment, greater levels of foreclosures in neighborhoods that were redlined, greater violence, physical factors such as excess heat, and including health outcomes like preterm birth and mental health as being worse in neighborhoods that were traditionally redlined. Slide. So in 2022, we did a study that was published in the American Journal of Public Health, where we wanted to just essentially look at how these historic redlining practices were associated with contemporary determinants of health in the Detroit metro area. Slide. And so when we talk about health determinants, we are particularly interested in knowing more about factors that promote better health opportunities. And I will make some of these connections later on to AMR. I promise I'm not here by accident. So some of those factors included median household income, home ownership, employment, high school education, children living above poverty, health insurance, less working commutes, and low air pollution. And what we wanted to design was a determinants of health index that was more specific to the Detroit area. These indicators were designed and developed in collaboration with about 8 different community organizations in the metro area. Slide, please. So as you can see on the left-hand side, you have the historical redlining maps. If I had a pointer and would show you, the concentrated red area is more aligned with where downtown Detroit is today. And you can see the outline with the furthest out city on the left top side being Pontiac. And so as a reminder that the redlining maps were more designed for urban concentrations, so that's why there's some gaps in the map. And then on the right-hand side, you see the determinants of health index, where the higher the index, so the darker the color, indicates more favorable health conditions. And so here you could see with a visual comparison of these two figures suggesting considerable overlap with census tracts with grades of green tending to have higher contemporary DOHI scores today, while those that are indicated in red are associated with lighter blue or gray scores. Slide. So to put this into perspective, this table shows the neighborhoods that have been designated historically with an A grade or green fared better across most contemporary indicators, so that first column. And we put it in perspective comparisons to the red neighborhoods, redline neighborhoods. We saw that there was a $60,000 difference in present day median household income between the two neighborhoods that were historically green lined compared to those that were historically red lines. And we also see an almost 30% difference in home ownership between these two neighborhoods. Slide, please. So all of this adds up to historical, that we see this clear link between these historical structural racism and the housing system leading to contemporary health inequities. As mentioned, we know that urban areas were mostly impacted. And something that is less discussed in the literature is there's so much attention on redlined areas, but there isn't as much discussion around green-lined areas where they have accrued this larger relative benefit over time. And in the literature, we refer to as resource hoarding. So essentially, all these resources that are being put out, certain neighborhoods have greater uptake of those resources compared to others. Slide, please. So this is a slide you've all been waiting for. So what are the implications for antibiotic-resistant bacteria? And again, my apologies, I'm not as well versed in AMR as I am on the other side, but housing in neighborhoods can be associated with antibiotic-resistant bacteria through various pathways, and these are ones that have been established in the research. So we know overcrowding conditions, so multiple people living in a house can put them at higher risk for faster infections. We know that poor hygiene and sanitation can lead to increased risk of acquiring infections. So just to also provide it, during COVID-19, right before COVID-19, Detroit City saw an increase in water shutoffs due to late paying water bills. And this was a huge issue in terms of when COVID-19, the first prevention that was put out was wash your hands and clean everything. We also talk about contaminated water. We saw in Flint, Michigan, but not just Flint. Right now we're having another huge lead increase issues in Benton Harbor, just across the state. But contaminated water can increase risk of infection. We also know that folks that are more housing insecure are more likely to show up constantly in ERs. And we have a study looking at readmission rates, and we know that more contact with healthcare systems associates with healthcare is associated with infections. And we also talk about lack of housing affordability and its impacts on paying for other things, including food and medication, or the lack of medication adherence that occurs. So again, another reason why folks that are housing insecure show up in ERs due to their lack of being able to adhere to the treatments that they're provided with. And please note, I am not talking about homeless populations. I'm actually talking about folks in low income and middle class currently in the United States. Homeless populations is a whole other issue. And so I'll leave you all with this again, because I do find that I do say this a lot. Housing is a determinant of health, and as you can see, it is a determinant of antibiotic resistance bacteria. Thank you.
Thank you so much, Dr. Nadampally.
Hi. Thank you all for the invitation to speak today. I am very excited to share the results of a scoping review my team has just recently completed on the role of race, ethnicity, and socioeconomic status in colonization and community-acquired infection with increasingly drug-resistant pathogens. Next slide, please. So first, I want to talk about the motivation for this work. I'm an environmental microbiologist. Full disclosure, I had not thought deeply about all the ways the social determinants of health could intersect with AMR until COVID-19, when we saw all of these disparities play out in front of our eyes. And I was in the Boston area at the time, which was really strongly affected by COVID. And so I started to think deeply about the work that I did in AMR and have been doing for quite a while. And I thought about this sentence that I'm always writing in my manuscripts and my grant proposals, that antibiotic resistance will affect us all. And I started to think, okay, but what about this more nuanced question of will resistance affect us all equally? That's something I had not thought about in great detail. And so I discussed this with colleagues at Tufts University, which is where I was based, and we decided to do a preliminary literature search. Now, at that time, and this was 4 years ago, we found relatively few studies describing racial or ethnic disparities in infections with pathogens that the CDC had flagged as being serious or urgent health threats. There were some exceptions to this. For example, there is quite a bit of literature on MRSA, but there were a lot of gaps as well. However, at the same time, there did seem to be this pretty robust body of literature showing that there were clear differences in risk factors for these kinds of infections, some of which are depicted here. So, for example, we know that there are differences in terms of occupational exposures to livestock, for example, to nursing homes, to long-term care facilities by race, ethnicity. As we're going to hear about later, there are differences in antibiotic prescribing practices, potentially differences in non-prescription antibiotic use. And so we decided to write a call to action for scientists, for physicians, to start thinking more deeply about how the social determinants of health might be intersecting with AMR in their own work. Next slide, please. So over the last few years, we've basically just been heeding our own call to action. With funding from the ARLG, we are in the middle of conducting a series of systematic reviews and meta-analyses on this topic. Now, the first step prior to doing a systematic review is to do a scoping review or a global evidence map. That's what we've completed to date, and that's what I'm going to be sharing results from. So the goal of the scoping review was to systematically compile evidence for associations between individuals, so at the individual level, individuals' racial or ethnic background or socioeconomic status, and their risk of colonization or infection with select community-acquired pathogens, which are listed below, that are increasingly antimicrobial resistant. So we first did this search in 2021. We identified, it's cut off, just over 1,000 citations, and we ended up extracting data from 87 studies. Next slide, please. So we actually ended up with so much data that we decided to write 2 scoping reviews, one focused on SES and the other on race ethnicity. I'm going to present both sets of results today. For our SES scoping review, we were able to extract data from 50 studies from 14 countries. You can see that many of those studies were from the United States, but we did have representation from all across the globe. Once we had extracted that data, SES is sort of this umbrella term. We grouped the information we had extracted into these 7 categories related to educational attainment, healthcare access, income, crowding, SES deprivation scores, which I'll talk about in more detail, urbanicity, and WASH. Some caveats to what I'm going to present today. Even though we extracted data from 50 studies, many of these studies, while they reported the outcomes of interest stratified by socioeconomic status, they did not conduct any sort of statistical test of association. So what I'm going to describe right now is just these studies that did look at a test of association. Also, we saw mixed evidence for the effects of urbanicity and water, sanitation, hygiene access on the outcomes of interest. So those are presented in the preprint, which you can access through the QR code, but I'm not going to discuss them today. Next slide, please. So first, we consistently saw that lower levels of educational attainment were associated with higher risks of colonization, with multi-drug resistant E. coli, ESBL-producing Enterobacterales, and Klebsiella pneumonia. We also saw higher risks of infection with bacteremia caused by Staph aureus and E. coli, MRSA, and drug-resistant E. coli. And you can see that this negative association was described in countries all across the globe. Next slide, please. We also saw that lower levels of healthcare access were associated with higher risks of colonization with Staph aureus and MRSA, as well as infections with MRSA, multi-drug resistant UTI, and ceftriaxone-resistant Enterobacterales. One thing I want to note here is that only studies from the United States described healthcare access as an indicator of socioeconomic status, which I think says a lot about healthcare in this country. Studies described healthcare access or investigated healthcare access in different ways. Some studies looked at the effects of having no insurance at all or public insurance versus private insurance. Others looked at the effects of living in a medically underserved area or relying on a medical interpreter to access care. Next slide, please. We also saw that lower levels of income were associated with higher risks of colonization with E. coli and higher risks of infection with MRSA, MISA, skin and soft tissue infections, and bacteremia. Interestingly, studies looked at income in different ways. Some people looked at it in terms of personal, individual level income. Others looked at it in terms of household level income. Others looked at the income of the neighborhood in which a patient lived. And at all 3 levels, we saw this negative association. Next slide, please. We consistently saw that higher levels of residential crowding were associated with higher risks of colonization with MRSA and Staph aureus and ESBL-producing Enterobacterales, as well as skin and soft tissue infections. As we just heard from our previous speaker, crowding is a well-established risk factor for the spread of infectious diseases, so I don't think this is a particularly surprising finding, but it was reported in countries across the globe. Next slide, please. We also saw that higher SES deprivation scores were associated with higher risks of infection with MRSA, skin and soft tissue infections, and drug-resistant E. coli. So I have a definition of deprivation scores on the slide. A deprivation score is a composite measure of area-level deprivation. So these indices compile information for a geographic area on income levels, employment, housing status, educational attainment. Typically, well, I think always, higher scores indicate greater deprivation. So neighborhoods or geographic areas with higher deprivation might be at higher risks of disease. They might not have great resiliency following disasters, things like that. And there are many different kinds of scores out there. And you can see that this association was described in multiple countries, again, across the globe. Next slide. So an important goal of a scoping review is to also identify limitations in the current evidence base. So some of the limitations that we found, I mentioned that we were able to extract data from 50 studies. There were many, many more studies out there that were describing colonization or infection with the outcomes of interest that clearly had data on the socioeconomic status of patients or the populations they were describing, right? So you can think of your classic table 1 of a manuscript. That information was described. but the outcomes of interest, like that information wasn't described, stratified by the outcomes of interest. And so for our purposes, we weren't able to extract that data. Most studies aren't exploring correlations between these SES factors. So obviously, many of the characteristics I've shared with you are highly correlated with one another in specific communities. However, because people aren't exploring these correlations, I can't tell you which of these factors is truly driving some of these associations in the communities that were studied. Most of the studies we included focused on Staph aureus or E. coli, so there are gaps in many of the pathogens of interest. All or nearly all of the studies we included from the United States relied on medical records. Again, because of our healthcare system in certain communities, this is unlikely to be representative of the population. So there's a real need for community-based studies, specifically of colonization. Potentially environmental surveillance could play a role as well. We also noted that very few studies were conducted in low and middle income countries, which is a problem. I think we all know in this room that LMICs are expected to be and are currently experiencing the greatest burden of antimicrobial resistance. We know this at a country level or at a regional level, but because we don't have great evidence about the social determinants of health that are driving colonization and infection rates in these countries, we don't know what communities in these settings might be most at risk. Necessarily. So this, I think, is a major gap. Next slide. Okay, I'm going to quickly share results from our race and ethnicity scoping review. We identified 54 studies from many fewer countries, only 5 countries. Most of the studies we included were from the United States, but we also identified a good number of studies from Israel, Australia, and New Zealand. I just want to reiterate that there is absolutely no biological reason why somebody should be at higher risk for colonization or infection with a pathogen, including a drug-resistant pathogen, based on their skin color or the ethnic group they identify with. Nevertheless, because race and ethnicity is so closely intertwined with the social determinants of health, due to structural racism, as we've just heard about, often in many countries due to a legacy of colonialism, we do see differences by race and ethnicity. Historically, race and ethnicity was not necessarily examined in conjunction with the social determinants of health, so we thought it was important to extract this information. Next slide. Just one summary slide on our results here. In the US, we saw fairly consistent evidence for Black persons relative to white persons being at higher risk of colonization or infection with MRSA, although not necessarily for Staph aureus, which was interesting. There also seemed to be consistent evidence for Hispanic persons, again, relative to white persons, being at higher or equivalent risk of colonization or infection with multi-drug resistant Enterobacterales. In Israel, the studies that we included described consistent evidence for Bedouin persons relative to Jewish persons being at higher risk of colonization or infection with MRSA and AMR UTIs. And just to note that we are using the terminology that the study authors used. And in Australia and New Zealand, there again seemed to be consistent evidence for Indigenous populations from those countries relative to white persons being at higher risk for Staph aureus and MRSA infections. Some of the limitations from this body of work, again, many studies reporting race and ethnicity, but not reporting race and ethnicity stratified by the outcomes of interest, so we couldn't include that data here. A major limitation is that I don't think any of the studies that we included described how that race ethnicity information was collected. We don't know if participants actually identified as these races or ethnicities, or someone just assigned them that race or ethnicity based on what they look like or based on their last name. So I strongly believe that, going forward, if people are going to report this information in papers, they need to report how that data was collected. It's a limitation to interpreting our results. And then we also identified very few studies that included Indigenous populations from the Americas. Next slide, please. So overall, I think we all understand that race is a social construct. Nevertheless, it appears that historically marginalized populations across the globe are at a higher risk for AMR colonization and community-acquired infection. Again, these differences are a result of the intersection of race, ethnicity, and the social determinants of health. However, there is a critical need to delineate what these underlying causes of disparities are with priority pathogens in future work. What are the social determinants of health that are most important in specific settings? We don't know. And I think this is a real roadblock to ongoing efforts by you all here in the US government to equitably prevent, diagnose, and treat bacterial infections that are increasingly antimicrobial resistant. So a call to action for everyone to continue to develop work in this area. Next slide, please. So I just want to thank the wonderful team that has been doing this work, honestly, mostly as a side project for the last few years. Researchers at Tufts and at Emory, and a special congratulations to Addison and Sampson, who just finished their MPHs and graduated last week. Thank you all for your attention.
Thank you so much. We'll move to our third speaker, Dr. Abdul Mutakabir.
Hi, everyone. Thank you so much for having me here. Jacinda Abdul Mutakabir, but I do go by Jam, like peanut butter and jam, so feel free to use it. So I'm going to present to you all today on exploring the intersection of racism, drug resistance, and vaccine equity. Slide, please. So currently I practice in San Bernardino County, California. I'm actually from Detroit, Michigan. So it was encouraging, and honestly, Detroit is the reason that I began doing work in this area. So it's an honor to be featured here amongst these great panelists. So San Bernardino County is a part of the Inland Empire. The Inland Empire is the fastest growing region, is one of the fastest growing regions in the United States and one of the fastest growing in Southern California. So due to housing in the Inland Empire oftentimes being lesser than the California region as a whole, we do see an increase in racially and ethnically minoritized individuals, specifically those that identify as Black or African American or Hispanic Latino within the Inland Empire area. When we consider the COVID-19 pandemic and just the growth of e-commerce, we've seen e-commerce increase almost 300% since the COVID-19 pandemic. And over 90% of the increased growth in Southern California has been in the Inland Empire. So when we consider and when we think about just the increase in factories to go ahead and make these products, well, we have to consider the increase in pollution and carbon emissions. And when we think about that, well, we see that growth right there in that Inland Empire region. And when we think about, you know, the carbon emissions and and so on and so forth, but we also have to think about the increase in lung illnesses, both acute and chronic. So we do see an increase in asthma as well as COVID-19 and RSV at far higher rates in the Inland Empire when compared to other regions of Southern California. Well, now we have to take it back and bring it down to a smaller scale. Racially and ethnically minoritized individuals are 3 times more likely to reside in these highly polluted areas. Slide, please. So when we consider these things, when we consider environmental racism, I think, you know, the previous 2 speakers really set it up for me to really talk about how they play into just each area of a social determinant and can really go ahead and contribute to inequities. So when we consider the impact of environmental racism on education, well, individuals that identify as racially and ethnically minoritized are less likely to matriculate through higher levels of education, meaning they're more likely to occupy these roles in these factories, which can then compromise their health. But more importantly, when we think about the growth of those factories, more than 20% of those factories are now being developed around school areas where the children, racially and ethnically minoritized children, grow, they learn, they play. So that's something that we have to consider when we're thinking about the impacts. When we think about socioeconomic status, because of the pricing of creating these factories, they are more likely to be in areas of lower socioeconomic status. Individuals of racially and ethnically minoritized groups are more likely to reside in areas of lower socioeconomic status, thus increasing their exposure to these very bad things. When we think about the environment, so I think it comes without mention. We talked about the erection of these factories. Well, the creation of those factories and those environments then increase those carbon emissions and the pollutants that we previously discussed. And what we can say now is that cancer rates, and then as I previously discussed, lung illnesses are far higher in these areas when compared to others. And then access to health services. Well, in the Inland Empire, we are one of the areas included in HRSA's list of those places that are now experiencing healthcare shortages and healthcare practitioner shortages. So now in addition to having these conflicts and these interactions with the social determinants of health, now folks don't have access to go ahead and receive care should they be impacted. So we can go ahead to the next slide, please. So in addition to the inequities and social determinants of health and then the environmental racism that I previously discussed, my group and I then launched, we began to do research on inequities in antimicrobial resistance and stewardship. So one thing that we uncovered were racial disparities among candidemic patients in the Southern California hospital. So the Loma Linda University Hospital, Loma Linda is the second, is a top ranked hospital, the second top ranked hospital in the Inland Empire, which provides care to the inhabitants. So this was a retrospective study that we conducted, and we actually separated it into cohorts because of the lack of data that exists that disaggregates racial groups. We thought that it was important, and we made it a priority to do so. So when we disaggregated this data, we then created two cohorts. We compared non-racially and ethnically minoritized patients to those that were racially and ethnically minoritized. So essentially what we saw was that racially and ethnically minoritized patients were more likely to have candidemia infections. And then with these candidemia infections, when compared to their non-racially and ethnically minoritized cohorts, our REM cohort was younger on average, about 5 to 7 years or so younger in terms of their presentation with the candidemia. Also, they were sicker upon presentation. They were more likely to be in the ICU. They were more likely to be hospitalized for a longer duration of time. They were more likely to have a TPN. They were more likely to have an indwelling catheter, and also more likely to have chronic comorbidities, which may have aided to them being hospitalized with the candidemia. But one thing that we saw, which was really significant to us, was that when we considered the non-Candida albicans species that were growing, we saw differences within these cohorts. So within our minoritized cohort, we saw an increase in Candida parapsilosis. In our cohort of non-racially and ethnically minoritized patients, we saw an increase in Candida glabrata. So with Candida parapsilosis, we were, of course, very nervous about this because we know that there are increasing rates globally in terms of resistance. And we saw that at our hospital, more than 20% of those isolates that we saw were actually resistant. So not only are we seeing just these inequities, but we're seeing in the social determinants of health, but we're now continuing to see like these disparities as far as it relates to antimicrobial resistance. And then when we're seeing the disparities, we're seeing a difference in those really bad bugs that we should be concerned about. But more importantly, next slide, please. It's opening our eyes to just how these things are so additive in nature. So when we think about environmental racism and the obvious impacts on social determinants of health, and then we combine that with the increase in just the multi-drug resistance, particularly as we've observed it across minoritized populations. Well, then for me, that then heightened my awareness to say, well, now we have to target upstream. We have to get there before individuals make that interaction or have that contact with the healthcare system. How is it that we can prevent them from ending up there and potentially having this exposure to the bad bugs? But more importantly, how do we have maximum reach? And with that, that really turned my interest to promoting the uptake of preventative therapeutics by way of vaccinations. Next slide, please. So this began during the COVID-19 pandemic. Loma Linda University had the largest vaccination site in the Inland Empire or in San Bernardino County. We were vaccinating anywhere from 1,000 to 1,900 individuals per day at the height of the COVID-19 pandemic. But within the first 3 months or so of launch, what we noticed was that racially and ethnically minoritized patients, irrespective of occupying a large number of the hospital beds, were less likely to go ahead and be vaccinated in the clinic. So what we did is we created tiers for encouraging equitable vaccine access and uptake. So essentially what it began with was the engagement of Black faith leaders, particularly in the Black community, because that's where we saw the least amount of uptake. So it began with the engagement of Black faith leaders, which included the Congregations Organized for Prophetic Engagement, a Black faith group that I continue to work with to this day. And then we proceeded to the delivery of vaccine education. I think it was very important to us and very important to me to make this a twofold accessibility approach. I think that there's more than just providing the vaccines. We have to provide education because I believe that education creates an opportunity for agency, something that's been historically taken from marginalized marginalized communities. And then the creation of low barrier community vaccination clinics following the education to make it easy and accessible for folks to be vaccinated should that be their choice. Next slide, please. So here I have the results following our first effort. So that first effort was the engagement of the Black faith leaders. And then we went ahead and we had, at that time, it was a webinar providing education pertaining to the COVID-19 vaccines. And then we went ahead and we had a vaccination clinic that I led with myself and then my amazing students that came and participated. So what you'll see here with this data is a comparison of the mass vaccination clinic site that Loma Linda had, as well as our community vaccination clinic. So what we see here is that within that first 3 months, we, of course, did not see a great representation of Black or African-American individuals within that mass vaccination clinic site. But this was our first and the only one that we had at that time, community vaccination clinic. And what we saw was that the majority of those individuals that were vaccinated, more than 80% identified as Black or African-American. And for us, that was a necessary overrepresentation of a previously underrepresented group. So we move forward and we continue to provide vaccinations in this manner and in this way. And to date, we vaccinated over 3,600 individuals using this model. But we felt that this data showed to us the importance of bringing forth education alongside the vaccinations. Slide, please. So using this model, we've continued this effort to go ahead and address influenza disparities that we're now seeing. Of course, with the COVID-19 pandemic, we're seeing a cessation or a reduction in the vaccination rates for other respiratory diseases. So noting the success that we had in the tiered approach, we geared it to another illness. So we move forward, and from August to December, similar to what my colleagues said, you know, oftentimes doing this for free and outside of my usual requirements for work. So from August to December, I go into San Bernardino. So I'm now in San Diego, so about an hour and a half away. And we received funding from CSL Secures to continue this work to launch our 5 vaccine education events. So what these education events include are an educational session. Included in that educational session is a pre-survey and a post-survey that's developed based upon the health belief model. And what that survey does is it assesses perceptions about risks, perceptions about benefits in terms of vaccination, and then also the change in knowledge. And if that change in knowledge then evokes the behavioral change in terms of the want to receive or intention to receive the vaccine. So we did have 3 major then after the vaccines, after the education, my apologies, we go ahead and we have a community health fair where we provide vaccinations. We also do blood donations. We do bone marrow testing. We do CPR training. So we really try to go ahead and include things that people of minoritized groups will have lesser access to should they not be able to receive it in this community forum. So within those 5 education events, we had 3 major counties represented: San Bernardino County, LA County, and Riverside County. I do want to denote that LA County is about an hour and a half outside where these events take place. And then we do use a deprivation indice within this research. So I use the CDC SVI index tool to go ahead and I like to characterize who are the patients that we're serving and that we're seeing. And what we saw was that 100% of the individuals that participated in this effort lived in either a medium high or high vulnerability area. So here you can see just a breakdown of the folks that we had participate. The bulk of the individuals were 55 and up, Black or African American, which was the target, and then majority of which identified as female, but we definitely were able to get those very high risk individuals. Slide, please. So I did want to go ahead and do a knowledge check just for perspective. My apologies that the percentage numbers are small, but I hope that you all are able to follow along. So if you look, the blue color will denote the pre-survey responses. So these are true or false questions that are asked about certain topics pertaining to the vaccination. So just vaccine severity and so on and so forth. And what we're seeing is that we're having an increase following the receipt of that education. So the green color denotes the post-survey. So these are, once again, true or false, the increase denoting the correct answer. But I call the knowledge check to the right. I talk about this with my students, and I call it our money shot. But when I look at the individuals, so 65 and up, having that education that there are stronger vaccines available for them, we're seeing that, you know, that lesser percentage in comparison to the post survey. And considering the folks that we were serving, we're definitely able to go ahead and maximize the education, but also mitigate that risk for a group that maybe wouldn't have had that before. And then also what we see was for COVID-19, I thought this was a really big point, because if you all have been following the data and just what we have been seeing nationally, was that folks, they felt that, well, I got the COVID vaccine, I don't have to get the flu vaccine. That was not the case in this community, but I want to make it clear that I have been providing COVID-based education for the last 3 years. So I think it showcases, one, knowledge, but also just when you have sustained knowledge, how you can have sustained commitment to the vaccinations. Next slide, please. I do also want to just see how that knowledge change, or show how that also reflected in the behavioral change, or just the intent to be vaccinated. So we see in that pre-survey, about 39.7% of folks said that they were very likely to be vaccinated before receiving any education. Well, following the receipt of education, 72.2% of folks said that they were extremely likely to be vaccinated, and then 75.9% of folks said that they were extremely likely to go ahead and recommend that vaccination to a friend. I thought that this was extremely important, because if we think about just national statistics, Black individuals are 50% less likely to be vaccinated when compared to non-Black individuals. So I thought that was very, very good to be able to see that intent to be vaccinated. Next slide, please. And then we can see that intent then carried out in some cases to be action. So we were able to go ahead and provide 96 vaccinations in our vaccination clinic. 40 of those vaccines were influenza, and then 56 of those were COVID-19 vaccines. When we consider the influenza vaccines, 100% of those were given to those individuals in areas of high vulnerability, and then the bulk of which being in those that are 60 and up. When we consider the COVID-19 vaccines, the bulk of those vaccines were given in areas where less than 50% or 65% of the population had been vaccinated against COVID. So I'll close out with this final slide, please. So when we look here, we do also ask questions to go ahead and assess how it is that we can include other things and target other areas for education. So when we look at just the first responses, what we can see, or just the impacts of race and racism on how it is that folks receive care, what we can see is that individuals, they definitely noted the impact that race can have on them receiving care, or the impact that race can have on how it is that they feel their government provides them care. But I do want to bring us to the point where we see racism makes a difference in how it is that they have access to medications and treatments. But in that final place, we see that because of race, the individuals or the participants that answered this question did not say that the impacts or influence that race and racism had should keep them from trusting the vaccines or keep them from receiving those vaccines. So I think that's the important piece, and that really shows us that with a commitment and a sustained commitment, that we can go ahead and provide education and provide services and have people really take heed to them, should we give it in that way and make it accessible. So I have one last slide just to round everything out, but more importantly, to just showcase that through the success that we have seen through the community academic partnership and through this intervention, we do hope to eventually include education about AMR and continue to use this as a model. Thank you so much. Thank you to my team.
Thank you so much. We'll move to our final speaker, Dr. Marcelin, who's joining us virtually.
Thank you so much, and appreciate being able to be a part of this presentation. I also want to thank the moderator and the panel session coordinators for teeing everything up so brilliantly, because I'm talking today about antimicrobial prescribing disparities and the pursuit of pharmacoequity, which is a term I'll introduce to you throughout this talk. But thanks to my esteemed co-presenters, I will, next slide, not spend a lot of time talking about what health inequities are and what exactly those disparities that we have observed in the diseases that we're treating with antibiotics, and instead move straight into understanding what the concept of pharmacoequity is within, and the role that it plays with antimicrobial stewardship for identifying and mitigating the drivers of the inequities that were previously described. And throughout this time, we will talk about some of the things that we've seen as it pertains to inequities in antimicrobial prescribing. Next slide, please. So one first slide, just to remind us all why we're talking about this in the first place. This is important for a lot of the reasons why my colleagues have shared that are impacting the individual patients who are affected by these antimicrobial resistant organisms, and the hospital systems and their communities. And for practitioners, it's also something that should be a priority because it is a quality and safety issue. And this is something that has been designated as a priority by the Joint Commission. And so what I'd like to do is reframe for those who are listening what the whole point is of thinking about antimicrobial resistance and antimicrobial stewardship through a lens of equity is thinking about it as a quality and safety priority. Next slide. One of the ways that we can consider doing this from a global antimicrobial stewardship standpoint really is starting off with the thought of a plan, do, study, act cycle. And that starts off by identifying what those inequities are. And so all of the work that has been done to put in to identify what the disparities in Staph aureus or collapses and so forth, that is important for us to know where are we starting and what does that have to do with the actual prescribing differences that we're seeing in our patients. Dr. Abdul Mutakabir and I and some other colleagues put together this EASE framework for antimicrobial stewardship programs to think through how to integrate equity into those stewardship efforts. And as I introduce you more to the concept of pharmacoequity, hopefully you'll be able to see how that is integrated. Next slide, please. There's a lot that we have to do to reimagine antimicrobial stewardship through a lens of equity. And so we've talked a little bit about some of the public health impacts and how we need to be mindful of the impact of environmental racism and structural racism as a whole on prescribing equity and antimicrobial resistance. There are other factors that need to be taken into consideration. For example, access to antimicrobial stewardship programs. There are a lot of ASP deserts across the country that are needed to be filled in order to have a more robust approach to reducing antibiotic resistance. And then looking at the prescribing itself on the individual level, what are the opportunities that exist in order for us to influence the reduction of inappropriate prescribing? And so that brings us to pharmacoequity, which we'll start talking about in the next slide. So this concept of pharmacoequity, I've said it a few times now. This was coined by one of my colleagues and friends, Dr. Utebe Essien, who is currently at UCLA. And the concept states that pharmacoequity is that value that ensures that individuals, regardless of their race or ethnicity or socioeconomic status, will have the highest access to the highest quality medications that are required to manage their health needs. And Dr. Essien has done a lot of this work as it relates to several cardiovascular issues, but the reality is pharmacoequity is a concept that can be applied broadly. And I see a lot of very important aspects of infectious disease and antimicrobial resistance and stewardship that require us to look at addressing these issues through a lens of pharmacoequity. Next slide. And so breaking it down a little bit further, there are different steps when we think about antibiotics and how they get to our patients and how we develop antimicrobial resistance. And these are the different steps along that pathway of pharmacoequity that there are opportunities for us to stop and consider what are some of the ways that we can make changes that will change outcomes in the future. So we're talking about medication development, from what funds are allocated to new medications, what about the clinical trials and who is participating in the clinical trials? What about prescribing equity? And is that a result of clinician bias, structural racism, and what can we do about that? When we have patients who are prescribed medicines, do they have the ability to actually receive or access those medications? And how often do they actually get to use the medicines once we've prescribed them? So each one of these is one stop in the pathway of pharmacoequity that ultimately has to be considered both in its separate points, but as a whole. Next slide. So starting off with the development and what funds are allocated to new antibiotics. This is a slide that is not specifically related to antibiotic resistance, but I think is a really good example. When you think about two rare diseases, cystic fibrosis and sickle cell disease. These are both conditions that are chronic and require lots of repeated hospitalizations that affect a small subset of the population. You can see on the left-hand side the table that shows what the U.S. birth incidence is of both of these conditions, as well as additional information about what sort of funding is applied to each of the conditions. On the right-hand graph, you'll see the timeline of when new drugs have been developed to treat both of those conditions. So what we know is that the U.S. birth incidence of sickle cell disease is much higher in Black individuals, people of African ancestry. And cystic fibrosis has a higher U.S. birth incidence in people of white race. And even though they are both recurrent, chronic, and have multiple hospitalizations, we see very stark differences in how much funding is applied to the understanding of these conditions, as well as the research output and how many papers have been published, as well as the new drugs. Sickle cell disorder has only had 2 drugs that were approved, and now we finally have gene therapy as one additional way for us to deal with sickle cell disorder. But you can see over the many decades since this condition was described, there has not been a lot of movement as compared to cystic fibrosis, where we have many drug options, a lot more money that's being put into funding. And so this is something that needs to be addressed at the federal level, as well as nonprofit and organizational levels. How can we make sure that we are looking at these diseases equitably when they affect different populations and at different rates? Next slide, please. Once we move to the next session is the testing piece. Who's participating in the clinical trials? There is a lot of data that has been published on participation in clinical trials that have demonstrated underrepresentation of people who have been historically excluded from clinical trials, particularly those from racial and ethnic minoritized backgrounds. It's also, there's also been reports of just from a geographic ease of participation in clinical trials. The study on the right-hand side shows that there were geographic accessibility inequities, and people who lived more than 60 minutes away from the trial, so that's more than 1/3 of the United States population, 3/4 of the rural population of the U.S., and a half of native populations, indigenous populations in the United States, don't have access to clinical trials. So what's the point of talking about this? It's important that when we're testing drugs, that the people that we're going to be treating are adequately represented in these clinical trials. I'm an infectious disease clinician, and there have been many times when I am talking to patients about a new drug to treat their MDRO. They may ask me, well, doc, was this drug tested in people that look like me? And the reality is that many of our antibiotic clinical trials have not done the greatest job of ensuring adequate representation of people from minoritized backgrounds. And there was a recent publication in Clinical Infectious Diseases that looked at Staph aureus clinical trials and found data to support those statements as well. And so we need to do better about increasing representation in our clinical trials. Next slide. So the next step is antimicrobial prescribing. And so there is actually a good amount of data out there that has described some inequities in antimicrobial prescribing across multiple levels. So on the one hand, minoritized patients are less likely to be correctly diagnosed with a condition warranting antibiotics. So for example, children coming in with air complaints who are Black, less likely to be given a diagnosis of otitis media. When antibiotics are required for that otitis media episode, less likely to be able to receive antibiotics overall. We've seen that also play out in pneumonia diagnoses and other conditions where antibiotics are typically necessary. We have less being prescribed. On the inpatient side, data showing that Black hospitalized patients less likely to receive first-line skin and soft tissue infection treatment, would be more likely to get clindamycin, for example, for non-purulent cellulitis rather than cefazolin for hospitalized skin and soft tissue infection. We've also seen data that shows higher and more inappropriate prescribing in the southern region of the United States. We've seen that people living in rural areas are more likely to receive inappropriate prescriptions, as well as folks who have private insurance more likely to receive antibiotics. Next slide. Medication access is also an issue. So once we have the prescription that has been sent to the pharmacy, will the patients actually have the ability to pick up those prescriptions? We see on this slide that in 2015, 1/3 of all neighborhoods in the largest United States cities were pharmacy deserts, meaning that there were not pharmacies within a large mile radius of those people's houses, and that those pharmacy deserts affect nearly 15 million people. There's also in the neighborhoods that are predominantly Black and brown neighborhoods, pharmacies that are there are more likely to close permanently, thus becoming pharmacy deserts, or if they remain open, less likely to provide some of the types of access that folks may need, like immunization or 24-hour drive-through services, so that people can get the services that they need before or after work. Next slide, please. Prescription use is the next thing to consider on the continuum of pharmacoequity. And so this is an example of using the COVID-19 monoclonal antibody treatments. And so when we saw already that there were disparities in the diagnoses and outcomes of folks who were Black and Hispanic and from indigenous populations in the United States, looking at how people were actually receiving and using the treatments, you could see that there is less uptake, less use of these medications. And there could be a plethora of reasons, which my colleagues have already described, but this is something that we have to be aware of and trying to see, once we get down to that part of the continuum, what are the ways that we can increase that uptake and use. Next slide. So this is a figure that was published in a scoping review that I was a part of with Dr. Kim and colleagues at the CDC that really tried to address the point of what those drivers might be. We can talk about the numbers and the inequities until we're blue in the face, but if we don't do anything about identifying what those drivers of the inequities are, both in the development of disease as well as inequities in prescribing, we will just continue to run in circles. And so this was our attempt to use a socioecologic model to identify potential drivers at the national, community, healthcare, and individual levels. Next slide, please. So the general framework for achieving pharmacoequity starts with the premise that this is not the goal. but it's merely a tool to achieve overall health equity. And we should view it as a health imperative. And so when we think about all of the steps along the pharmacoequity continuum, the way that we want to take that next step to achieving it by mitigating these issues include improving medication access, mitigating prescriber bias through culture change and education, overall reducing prescription costs, and enforcing equity as a quality measure. Next slide, please. There are similarly actions for individuals, institutions, and public health organizations to take that will collectively act to mitigate the impacts of health inequities. And this has a role on addressing how we make the change for reducing antimicrobial resistance. And then the final slide, I just want to be able to remind the folks where we started with a Plan, Do, Study, Act type of cycle. This really has to start with collection of data. We need to understand what the inequities are. And once we have collected the data in a way that is reproducible and standardized, we need to then move on to identifying what those drivers are of the inequities, develop the mitigation tools, and then re-examine so that we can keep going towards the goal, which is equity being the lead and not a supporting actor in all of this. And with that, I want to say thank you again, and I will be ready for the panel questions at this point.
Thank you so much to all of our speakers. So now I will open up for Q&A. And I think we activate.
Thank you for sharing these data and for developing them in the first place and bringing to light the evidence that we can hang questions on, figure out what to do next, and so on. I really appreciate it. My question is, I'm curious, what evidence there is that gender is a confounding or modifier or covariate of any of these disparities?
Yeah, so great question. Thank you so much. But I think that there's definitely a lot of overlap when we consider intersectional identities and so on. So there was actually a study done, it came out of Denmark, and they did outpatient therapy, and they wanted to look at how deprivation may have played a role in just honestly the recommendation to receive outpatient antimicrobial therapy. And what they saw was that, you know, individuals that were more deprived were less likely to be recommended, but they saw that amplified at the intersection of gender. So women were less likely to receive a recommendation for outpatient therapy. Additionally, my group and I did a study on UTI infections, and we wanted to look at any differences, racial differences that we may have seen in urgent cares or emergency department. And then, of course, we saw that racially and ethnically minoritized individuals were more likely to be treated at the urgent care or emergency department with UTI, just a lot of times because minoritized individuals are less likely to have a primary care provider. So oftentimes we will report to these care settings, so the emergency department or the urgent care, with varying acuity. So we also saw that, of course, I mean, women are more likely to present with the UTI, but we saw it amplified at the intersection of age. So we saw a particular age range within like 30 to like 43 was where we saw the UTIs kind of more predominantly. So I think a lot of times due to that intersection and due to just these big areas of marginalization, so consider being a marginalized race, and then you tack on, you know, being a marginalized gender identity, it becomes very hard, and we really do see those disparities further exacerbated.
Great. And I'll just add, when we were doing our initial literature search, and I mentioned that we found a lot of disparities in risk factors for resistant infections, I mentioned occupational exposures being one of them. And we know that women are more likely to be filling roles related to patient care. So whether that's at-home nurses or in facilities, And these are often minority women. So there's another intersection there.
I would just add one more. There on the prescriber side, actually, there was data that was published by Dr. Valerie Vaughn and her group that looked at antimicrobial stewardship interventions. And so this is the antimicrobial stewards, pharmacists who were calling clinicians to talk about different decisions that needed to be made about antibiotic choices, that demonstrated that if the pharmacists that were calling were women, their interventions were less likely to be accepted by the prescribing teams than if the pharmacists doing the intervention were men. And so this has a lot of implications for the role of gender bias in clinical prescribing practices, especially when there are interprofessional factors that we have to take into consideration as well.
Thank you. Jason?
Thank you to all of you. Fantastic. So insightful, so wonderful to hear. You all touched on so many things. I wanted to ask, and I'm going to go to Dr. Abdul Mutakabir, or Jam, because I love that you like to go by Jam. You guys so nicely showed and have discussed what we all need to hear about the systemic racism that is present in our society. I'm from St. Louis. I can show you just all the stuff that was brought up. But Dr. Abdul Mutakabir, you kind of leveraged what I have been learning from my colleagues about the strengths of our not minoritized population, specifically in our Black communities. Could you speak to that efforts? Because and you showed that in that slide. Look, it wasn't trust, right? It wasn't trust. It was access, which I think gets at this notion that our communities are strong, and sometimes we talk about the deficits we put upon them, but not the strengths of them. Could you? I just would love to hear your thoughts on how you did that.
Yeah, 100%. And I don't know, I guess it ended up being serendipitous that I ended up on the panel with Dr. Rashanak. But I mean, even when I thought about, Michigan and just Detroit, one thing that I could draw on from my experience, so to give everybody just, a frame of reference, I was trained in vitro pharmacokinetics and pharmacodynamics. I was not trained to do any of the work that I do right now, much to my mentor's dismay. But for me, one thing that I took from growing up in Detroit is just the very strong Black faith community. And when I went to San Bernardino, that was one thing that really drew me into there, was just the very strong Black faith community. But I think a lot of times, just for marginalized individuals in general, we forget about how much of a role just religion plays in decision making. So it was, once again, serendipitous that Loma Linda, is a faith-based institution, but also has very strong connections with the surrounding faith-based organizations. But it's because of the Black pastors that I've been able to, develop this relationship and really keep this intervention going, so much so that they're included as authors, on all the research that I do, because they are by far, my key of entry. When we decided that we wanted to give, vaccines, and every time that something new happens, they're the first, in line to take advantage, because I call them oftentimes my chaperones into the community. And I think, that's really been the biggest lesson that I've learned, is to really take a back seat and to let the community really guide where it is that I take the education. In each iteration, honestly, it's led by the community. I let them, lead how fast we go, how slow we go, what we integrate. I really lean on the community in that way. But I think, like much to what you said, the strength, it really comes within the leaders that are already instilled, the leaders that are already trusted. And I think, it's our job and I take it as my job as a member of the community that can translate the scientific information to really just be, a vessel. I'm there primarily, and when I start my presentations, I say, I'm not here to force anyone to be vaccinated. I'm here to just provide education. And should you want to be vaccinated, or should it, be on your mind as something to consider, then you have the facts to do so. And I think, the power of them really seeing me work in tandem with the faith-based community, for them to have their pastors say, you know what, you can do, and they say concomitant administration. Like at this point, they probably have better lingo than I do, but they can attest to it and say, it's fine to do. I did it. I was fine. Their kids will come and participate as well, so that they can be advocates too. So I think that's the beauty of it, acknowledging the strength of the community and really leaning into that.
Great. Tim?
Well, thank you to all the speakers. I think it's very striking that the social determinants are critically important, and driving AMR and our understanding of those social determinants will help frame what interventions should be deployed. It's also very striking that there is a very significant impact on people's health and well-being as a result of structural racism in the United States, including some factors which have been state sanctioned. And that, I think, has to be recognized, and we need to consider where there might be state-sanctioned things that continue to have an impact today. So my question to the speakers is, are there national level or national scale interventions that they would recommend being prioritized? And are there opportunities for integrating an AMR lens into existing programs to make progress? Thank you.
I can just talk more broadly. I think the role of public health in all policies is a really important approach. In particular, when COVID-19 happened, CDC stepped in and put a moratorium on evictions. This was unprecedented. It was a very strong role because there was recognition that the majority of renters in this country were going to be hit financially due to the COVID-19 impact. So I think a health in all policies approach could definitely assist with some of these policies at the national and also at the state and lower levels.
I can just add, in the context of the scoping review we did, you're asking about interventions, and I'm not quite sure if we're there yet. I feel like we don't have enough data still here in the US. I know there are a lot of data fans in the audience, so I think this is okay to say that here. But I wonder, I have been thinking myself about, like, what can we leverage to collect this data? So some ideas that I've been thinking about personally are, I know that wastewater surveillance for antibiotic resistant bacteria has a lot of kinks to work out, but potentially there is news through CDC. Potentially that's a way to try to link social characteristics of communities to what we're seeing in their wastewater. I'm not sure if there's sort of cohort studies that are ongoing for other reasons among fairly healthy populations. Maybe we can be collecting colonization samples, for example. We have a huge gap in terms of understanding what people are colonized with in the United States, other than, for example, NHANES data. I know when I talk with clinicians, there's always an interest in trying to incorporate, like, social determinants of health questions into like outpatient visits. I, personally, not as a doctor, but as a patient, have never been asked a question related to that. But I wonder if, like, more progress on that front could be made as well. So yeah, I think, I just don't think we're at the intervention stage yet, but I think we could get there.
Dr. Marsland?
Yeah, I think I totally agree. And one of the things that I liked that Dr. Nanampali had said about the scoping review was the limitations of race reporting. And this is something that I've also seen in my work with clinical trial participant demographics as well. It's just a mixed bag. We don't have a standardized way and reliable and reproducible way of collecting and reporting data on race and ethnicity. And I know it is inherently challenging because race is not a biologic construct, but because of the way that the relationship that race has with society and ethnicity, there has to be a better way that we can collect this data reliably so that when we do the studies, we can do the subgroup analyses that we were talking about, both for the understanding what the prevalence is of these AMR in the populations, as well as the entry into clinical trials. I think that from a national level, federal level, there are opportunities to strengthen the policies that are already in place, and perhaps provide the researchers and the hospital's clinicians with the tools to be able to collect this information in a standardized and a reproducible way. And then the other thing that I would add is we have a long ways to go in trying to understand the role of unconscious bias in prescribing practices. And we can try to understand the structural determinants and the other drivers of what provides, what makes a person at more risk of developing certain conditions. But we also need to figure out a way to address the individual prescriber issues and understand them. And so more studies probably need to be funded to understand this on a larger scale.
Great, thank you. In the interest of time, I'm going to ask council members to request one person answers, and we'll go to Chris next.
Great. So this is for JAM. Just very, very interesting, very compelling, the results that you achieved through your interventions through faith-based leaders. I was wondering if you thought about how do you scale this? Going out of the 3 counties that you've really focused on, how do you take it, to the state level, to the national level? Is it train the trainers, developing a playbook? And yeah, just what's your approach for doing that, or have you thought about that?
I'm really taking it day by day. But so at this point, we started in San Bernardino. So now I'm working with the San Diego County, and we're working to branch out and to start in San Diego with hopes of starting in August. So I'm hopeful that we'll be able to at least cover 2 large regions of Southern California. But ultimately, it's the integration of my students. So I have a course at the University of California, San Diego. Shout out. So they allowed for me to do to start my own class, exploring the intersection of racism, antimicrobial resistance, and vaccine equity. So we just launched the course this past quarter. So I have 43 students enrolled, where they come and then, I invite them into my research agenda, honestly, and, walk them through what I'm doing. But more importantly, they also develop their own intervention. So following that, they also join me within the community, and they do that work as well. I think, I am working to scale, and I'm working to, scale it at the state, and then hopefully eventually be able to scale it more broadly. But I think, the growth of this type of work really lies within the students, and it lies within, the younger cohorts and the future of medicine. So it's my hope that, with this course that I plan to offer every year, that I'm able to train folks through that model to increase scalability, and to empower them to go forth and create their own accessible models.
Great. Libby?
Thank you. I could ask a million questions, but I'll ask one to Dr. Maddie. We've heard just yesterday, again, from Amanda Jezik from IDSA about the lack of ID clinician coverage, and there's work going on to describe that for pharmacists as well as nurse practitioners and physician's assistants, and determining the coverage in the United States. And a lot of the area that is uncovered is rural. And you said that a lot of your work described urban areas. And I was wondering, do you know of ongoing work to do the same sort of, is there a similar metric to the redlining in rural areas? And if not, this is a plea to, could you help us with that? Because as we try to solve these problems, we need to know that as well.
So I'm not as familiar with what's happening in the rural areas, but primarily I know one of the big issues has been that when research has been tried to be done in rural areas, urban metrics are used, which then does not help with their situation. So I know big issues around transportation infrastructure play a really big role. However, I do think it is definitely an area, especially on the housing front. Rural housing is barely described, and we know at the intersection with what's happening with the climate, that is a huge concern, as these are areas that are often hit very badly with weather conditions, and then leaving them in situations where not enough access or care is reached. So that is definitely a big issue.
Thanks.
Sorry.
Susan?
This is a question for Dr. Polly. I'm curious about, there was a time when the most wealthy and white individuals were at higher risk for MRSA because they were the ones that had the access and the demand of antibiotics. And there's been some sizable swings in different populations where now a lot of people are more au naturel. I don't want antibiotics. I want to, kind of solve my problems in a different way. And I was wondering if you could comment on whether or not there are differences by socioeconomics or by race in people's perception now about their desire to use or trust antibiotics.
That's a really great question. I haven't thought about that too much in the context of high-income countries. I mentioned most of our studies were from the United States, and we did, at least in the studies that we included, did see this sort of consistent trend of higher income, meaning lower risk at this kind of point in time. But there seems to be more variability in lower middle income countries. And I think it's for exactly the reasons that you're describing, where higher income people seem to be having more access and using more antibiotics in a way that's putting them at risk potentially of more drug-resistant infections. The body of literature isn't great out there. I think more work needs to be done. But at the same time, in some settings, there seems to be an environmental reservoir of pathogens that people living in poorer conditions might be exposed to, whether that's through water or food. So it seems to vary from setting to setting in low and middle income countries. And I think these two issues of antibiotic access and the ability to afford antibiotics, because it's not easy to afford if you're living in extreme poverty, and environmental reservoirs. And I think there's a lot more that needs to be worked out in those specific settings. I'm not sure that answers your question directly, but thank you.
Tom?
Yeah, thanks to all the speakers, but my question's for Jam. I was impressed by your focus on programs to increase the uptake of preventive practices in minority communities. And I noticed in your example program, you described engaging community leaders to kind of address education hesitancy issues, and then you also addressed access through putting the vaccine clinics in local areas. But I was wondering if you could comment on the relative importance of those two things, educational versus access issues, and their importance in limiting uptake of preventive practices.
Yeah, 100%. Thank you so much for the question. So for us, when we began with the intervention, I think that my biggest issue or my concern was that, we would have the vaccines there. So this was February 2021. I felt that we would have the vaccines there, but I knew that there may have been like a lesser willingness to receive the vaccine should we place them there. So we actually, we launched with uptake in both the Black and then the Hispanic communities of San Bernardino. So when we went to the Hispanic community, we really saw that it was more so an access issue because we were not doing the same education before we went into the community. But when we brought the vaccines, we actually had more folks come out to be vaccinated that identified as Hispanic, Latino in these predominant areas. But then we went to the predominant Black areas when we switched the vaccines. So when we went from Moderna to Johnson & Johnson, we saw that there were a lesser number of folks that came to get vaccinated because Moderna was not being offered. Johnson & Johnson was at that time. So I think to me, it made it clear that we had to do both. We had to make sure that we were providing education, and then also alongside those vaccines, and that every community wasn't created equal. We didn't see that same decrease in the Hispanic community. It was a consistent, 400 or more people are coming to be vaccinated. When we compared it to the Black community, we had 300, folks being vaccinated with the Moderna, but then with Johnson & Johnson, maybe 150. So it was very different, but it was also that big, difference in how we saw the Johnson & Johnson vaccines communicated to the community. So I think from that, what I saw was, it's important for us to educate. But I think, me being there as a trusted expert, when individuals had questions, it wasn't that they, had to come in and then get vaccinated and didn't have an opportunity to continue to engage. And I think that continued engagement has just been a testament to why we continue to see folks come and be vaccinated. So that's why we can, continue to use that type of model.
Great. We will go to our last question online from Dennis.
Thank you, Dr. Patel. And so I was very interested in this discussion, and Robin can probably guess where I'm going with this, but I heard people say they'd really like to know from the data people what the evidence says to guide future studies. So I'm going to give a shout out to the NIAID, Antibacterial Resistance Leadership Group. They have a committee on DEI, and I think Jasmine knows about, Dr. Marcella knows about this committee very well and has helped us in this area. But Melinda Pettigrew chairs that committee, and I think that might have been the paper you cited in CID, where they've not only looked at enrollment in trials and trying to identify bias and protocol construction and variables addressed, but they said, now let's figure out how to address this within trials. First step was that paper where Melinda's group used medical librarians to go through thousands of publications and identify them, and then try and this was for one disease, staphylococcal bacteremia, which involves a high level of resistance, to look at the variables. And to me, the most profound finding for that study, we found no definitions or benchmark from which to mark these. So I think that paper is the benchmark, showing how much we don't know, how little we could uncover from the literature, and calling for a more robust path forward. That's one disease and one approach. And they did publish at ECMID an abstract on racial disparities and the impact on Black females versus other populations in outcome for treatment of bacteremia. And they can't really say much more than why is that. And so we know that some of the highest affected communities are not the ones that enroll in the trials. How do you fix that? And so we've heard faith-based communities and could be a way to get at this. And we've got some ideas, and we're sure Dr. Patel took her notes on this too. But if you set an enrollment-based cap, you'll never get enough people in the study to say anything. So it's not just saying, we want to have X people from this group. You need to know how to get them in the trial. And we heard from a PACCARB meeting 2 or 3 years ago on the disparities that people were finding both from the patient side and from the prescriber side, in differences by groups on when antibiotics were given and not given, even to people within healthcare systems. So we have a lot to learn in this area. I just went on too long saying how stimulating this discussion was and how encouraged I am that maybe we can try and figure out in small steps how to get there.
Great. Thank you, Dennis. I think that's a way to nicely wrap up this session, talking about our way forward from here. And I'd like to thank all of our speakers, and I'll pass it back over to Joanna.
Thank you, Dr. Patel, and a sincere thank you to our powerful women panel that did an amazing job. Thank you so much. All right, so this is the time where our council distills down an insane amount of information and then gives us a 45-second kind of bottom line takeaway policy recommendation of your own volition and from your own subject matter expertise and opinion, just so we can take it into consideration as the council determines its next steps forward and where the direction the council should go into in 2025. I'm going to start on this side of the room. We'll go around and then we'll go into virtual world. So hopefully our agencies and anyone that's online, please be sure to turn on your cameras so we know that you're ready, willing, and able to provide your feedback. And we are going to kick it off with Dr. Lewin.
4 things. First, happy Infectious Disease Pharmacist Day. Then, yesterday we learned about we need workforce. We have a lack of workforce, whether it's infectious disease physicians, pharmacists, infection preventionists, pediatricians, and such. We also learned how powerful patient stories are and must continue to do that. And then today, wow, what a day. Clearly, in my opinion, we have learned that antimicrobial resistance pathogens know no age, knows no political affiliations, knows no religion, knows no race, knows no culture, keep adding knows, and seems to take advantage or does take advantage of our social shortcomings and targets the vulnerable. The AMR data we have is on an underestimate. The drivers are unknown, though we are learning more. And the story of the impact of conflicts, racism, climate change, you name it, is not fully told and will be ongoing for generations. And today and onward, we must continue to do what we're doing and act. Thank you.
Thank you, Dr. Newland. Dr. Zagmid.
How do I top that? So, of course, from my perspective, information is key. We learn a great deal of needs, knowledge, starting from a One Health approach to how the USG has to share data, all the way to what's happening in areas of increased need today. From my perspective, what's a very important theme here is there are three things we keep hearing about. So there is the data sharing and the knowledge creation component. There's a capacity building, to your point. And there's also new technologies. So how do we prioritize those things? Again, requires knowledge and data, which I hope at some point we can tackle in this committee. Thank you.
And my best efforts to be Jason Newland for a day, but as he did on a previous meeting, I'm going to say education, education, education. So a golden theme throughout the 2 days has been education, and that's both in terms of experts, healthcare workers, healthcare providers, veterinarians, etc., but also the general public. This is clearly an area where there is insufficient progress and more efforts needs to be made around education in all of those areas. I'd also want to add that there was one thing that is an opportunity I think that needs to be picked up on, and that is how can we integrate surveillance approaches so that human health related surveillance and animal surveillance are utilizing the same processes and systems and become much more efficient overall. Thank you.
So we've had a huge amount of fascinating information as always. I'm not going to try to sum up or create a general statement. Instead, I'm going to focus on the terms diagnostic and diagnosis. We toss these terms around a lot, and we have a tendency to confuse or conflate meanings, or at least I see this in the field often. We desperately need new diagnostics, but we also need innovative approaches to diagnosis. Diagnosis is we're going to be benefited by looking at diagnosis as a broader view of a diagnostic process, which includes both those diagnostics, new diagnostic approaches, appropriate integration of diagnostics and diagnostic approaches into care or stewardship, and then also diagnostic safety, of which there are many aspects, but delay of diagnosis is one. I think we would benefit from looking at all of that. And one agency plug, my agency is very interested in research applications on diagnostic stewardship and safety, if anyone is interested. Thanks so much.
No, this has really been a wonderful 2 days. One of the things that I really have always appreciated with our committee meetings is the stories from patients and patient advocates, and really appreciating the power of story, and really especially during this committee meeting yesterday and hearing from a number of different patients and patient advocates. The one thing I think an opportunity perhaps is these stories are often told to us, and basically our advocates and our patients are preaching to the choir here. We are all passionate about AMR, and I'm wondering if there's an opportunity for the committee here to kind of envision how we can really elevate and amplify those stories so that we are not just hitting the appropriate stakeholders who need to be listening and hearing these stories, but really helping to build a greater advocacy so we can really amplify the message and make the impact that we want to achieve. So I really, again, thinking about, the committee, how we can really kind of enable and enhance those stories that we hear at these sessions. Thank you.
Just echo, I think the last 2 days have been really interesting. It has really reaffirmed the complexity of AMR and the fact that it is a public health threat And it's also multifactorial. Just in the last 2 days, I've heard about how climate change, sanitation, how friendly we are with our pets, as well as environmental racism, how they all influence and potentially exacerbate AMR. So I think as we go back to our respective researches and as we work collaboratively, that adaptability and flexibility are two things that we should consider when we're thinking about antibiotic stewardship and approaches to mitigating and preventing AMR in both human and animal arenas. Thank you.
So in recognition of ID Pharmacist Day today, I'm going to frame my comments from the pharmacist perspective, who I've heard mentioned in the past day and a half as controllers of antibiotics, and Dr. Abusita's example from Mosul, to Dr. Vaughn's work that showed variability in acceptance of pharmacist steward advice based on gender, and a call from Ms. Carter yesterday for physicians and pharmacists to include patients as stewards. I'm struck by 2 points. In addition to our global recommendations in the report we approved yesterday, to engage the local context in the planning and implementation of all global stewardship efforts, JAM reminds us and highlights for us the importance that we do that also in our U.S. work around stewardship. And it's really important that we engage local leaders to do this in multiple settings if we're going to have success. And then also something we've discussed previously is the PACCARB multiple times and have recommended and also included in reports. Communication around AMR is essential to our success. And I believe it is an essential role, if not the top priority, for this new U.S. ambassador for AMR that we continue to recommend, including in the report approved yesterday. Thank you.
Well, it's been an amazing day and a half, and I don't have to tell anybody how complex this problem is, but I think it's solvable. And we need to really think about this complex problem from a system thinking approach and how we can implement different solutions based on that, because it's all interrelated. And one thing that sometimes we forgot, and I think somebody said at a conference not long ago, is that we need to bring economists into this role of One Health and bring it under the One Health umbrella, because we do need money and investments. And as somebody showed yesterday with that video from South Park, we need money to be able to show that investing in AMR and prevention really pays off. And how we can do that by gathering data, finding the way to measure the impact of AMR, finding targets, even though if they are simple measures like mortality and morbidity. But, we need to find a way to show to the policymakers, to the people that have actually the money, how we can make a positive impact. Thank you.
I will frame my comments strictly as a patient advocate or activist, as they call us today. I always enjoy our meetings and how rich the conversations are. Of course, we always start our meetings with a patient story, but the highlight for me was how Maddie's transplant was beautifully told by Michael Graziano, capturing not only Maddie's emotions, but her mom as well. And then, of course, the panel on advocacy, that was another highlight for me. It's a first time, and I hope we can continue doing that. Hearing from 4 different patients to bring change to healthcare. Wow, that was outstanding. And today, the highlight for me was how important education is, not only for clinicians, but also to the public, which I believe will just add to diagnostic safety and quality. Thank you.
I think I'm probably just going to echo some things. I think throughout all of the panel discussions, we really did focus on workforce development as a pretty considerable need. But I think the definition of what the workforce is has to be broadened to a lot of different stakeholders that I think we don't traditionally classify as kind of the healthcare workforce, which might help with some funding streams and trying to figure out how we can include like patients in our workforce, because those are all, community leaders and people in conflict zones and in providing community health care. So I think education and workforce development needs to have a really broad lens. I think that seems to be really clear because we can't reach certain places without defining healthcare workers differently. And I think that would include a lot of, on the veterinary side, that would include farm workers, people that we know are caring for animals and maybe don't necessarily have that structure to support their education beyond sort of on-farm education. So I think that is a really important thing. I think one of the things I took away from especially the patient stories and experience, and I don't know how to frame this more, that the brutality of healthcare at some level is something that we have to put into the conversation, is our focus on having antibiotics inhibiting our growth in other areas. And so I think that was sort of something, I'm probably not saying that very elegantly, but because we have these beautiful drugs, I wonder if maybe some of the approaches that we use might be inhibited from exploration. And I just was so profoundly affected by how much these people went through and how much suffering they experienced. And so I think that, because we rely on these drugs to kind of save our butts at some level from what we do, I just wonder if maybe there's also some attention that could be paid on innovation to avoid having to rely on these drugs so heavily in some of our disciplines. And then I also wanted just to highlight that we do have a lot of infrastructure, especially on the veterinary side, that we could definitely enhance and exploit. And I would just also say on the human side, we have structures, but they're more skeletons than fully fleshed out organizational support for a lot of these initiatives that we're talking about. So I think we need to make sure that we don't overlook that as well.
I thought this meeting was really exemplified the focus on context that was highlighted in the global report. And I'll limit the things that I have to say just to two things. We talked a lot about uncertainty in war and other things, lots of things that you can't prevent, a lot of things that are unfortunate. But the part that struck me is how the use of fake or diluted drugs really undermines trust in every way. And it builds in a level of uncertainty that is really unconscionable, and it affects providers and patients and what they can expect. And on a second note, I wanted to just highlight Dr. Craig's comment about decolonization. We heard a lot of opportunities from the patient story to the veterinary interface between patients and even most recently about the war-torn countries, about moments where prevention can be really powerful in the setting for decolonization. I just wanted to highlight again that these preventative measures that we have, whether it's washing your hands or doing decolonization, they're not going to work perfectly in the moment of desperation. And I think we need to right-size our expectation for things that in clinical trials have been shown to be highly beneficial at 20%, 30%, 40%. We have to really make sure that we right-size what we expect is the benefit in certain situations, and to make sure that we use the right concentrations and are looking for dilution concerns as well. Thanks.
Yes, so these sessions really emphasize the complexity of the problem of antibiotic resistance and the complexity of the solutions that we're going to need. As an epidemiologist, I really appreciate the discussions today of the population level drivers of AMR. As a researcher, I'm used to focusing on things like the movement of mobile genetic elements between bacteria, but as we saw today, movement of refugees between countries plays an important role as well. And we need to not only think about clinical breakpoints, but also dividing lines between neighborhoods as we look at the problem and solutions to antimicrobial resistance. So I think that one of the important bottom lines for me is the role of social and behavioral determinants of AMR and how important they are, and that we as a council consider recommendations in the future and the folks in the future. We need to be sure that we bring those social and behavioral aspects into the equation.
Thank you. This was a wonderful meeting. My comment today is inspired by Dr. Medipana's talk and the point that she made about how we focus so much on redlining and not so much on greenlining. So we learned today about the unequal distribution of risk and access to resources for people to be able to promote their own health. And we discussed a lot of downstream sort of point of care solutions to bridge the gaps. But I think it's really important for us as a council to keep in mind that this unequal distribution stems from social stratification and the concentration of political power. And I'd like to ensure that we don't ignore that the way that people with power actually benefit from these arrangements as we discuss solutions. Otherwise, I believe we're putting a Band-Aid on a severe and deep wound.
Amen. So from the level of my heart, I thought today was very intense and I just wanted to cry. But I'm a scientist at heart, I'm an optimist, and I believe in people. So I'm going to take it up a level from the level of my heart. So we learned today about AMR's association with the ecology of war and the ecology of environmental and institutionalized racism and inequity. But we also learned about the resilience and the strength of affected communities and the resilience and the strength of the people trying to make a difference, like many of our speakers. And I never heard about the Inland Empire until today, so maybe I should get out of Minnesota more.
I also want to thank everyone for a very moving 2 days of conference. I work in public health, and so my comments will be from that lens. I had 4 different topics. I'll be brief, but I just want to encourage us to emphasize, again, public-private partnerships. There are numerous healthcare-associated infections programs working on AMR in different settings, including we look at social vulnerability index to go into facilities that are highly affected. So I'm hoping that academics can partner with health departments because we're trying to get into those areas to look specifically at AMR in those settings, as well as issues of wastewater surveillance and education to promote vaccination. So I really encourage the public-private partnerships. Second, I thought the war zones for me were like the case stories. And I think that those are opportunities to raise awareness that the council could use. And I was really struck by the term that these war zones could be force multipliers for AMR, and I'm really worried about that moving forward. Third, I wanted to highlight again the issue of technologies, as was mentioned, because we really need automated reporting to figure out what's going on with surveillance and understand what's going on in the animal world, in addition to humans for surveillance. And last, I usually talk about this each time, is the vaccine for adults. We need such a program for people, for refugees, for shelters. We're really having issues with getting vaccination to people who need it. And there is no such vaccine for adults program. There is a vaccine for children's program, but that's something that I think we should also highlight from PACCARB. Thanks.
So I come from the background of being trained as an adult infectious disease physician and spending the bulk of my career in the pharmaceutical industry. I want to thank the PACCARB colleagues and all the panelists and the PACCARB leadership, and especially the PACCARB staff for a powerful, emotional, and highly important 2 days. So my career, infectious diseases industry and other things, has been one of loss when it comes to this space. I've seen this move from early in my career from being a concern to now where it's an urgent public health threat and a national security threat. We see the burden of AMR increasing and unfortunately driven by oftentimes horrific and or unfair practices and things around the world. I've seen the pipeline at a time when we need more and more solutions. I've seen the pipeline become totally inadequate in terms of many of the AMR pathogens and an increasing list of pathogens of concern. We talked about the loss of talent from the space, and I ran the infectious disease therapy area for a large pharmaceutical company for over a decade. And once the talent in ID leaves a pharmaceutical company, there's no one to talk to that knows how to spell AMR. So when you come back to say, well, somebody will pick this up later, surely they'll figure it out. I struggled to keep the company in the infectious disease business for years, and it gets harder and harder every day for companies. So now we have things that are propping up the system like CARB-X. Great push program. Many of the people in this room are associated with that. What happens if there's no economic model at the end of that? We continue to give money to companies to watch them go out of business, not a sustainable model. We say the AMR Action Fund, and from my understanding, they have a timeline associated with when they're willing to put money into this, and they're counting on economic reform. The model has failed in terms of the return on investment for companies. Even when one goes out of business, there's no one to pick up a compound, even pennies on the dollar, because you cannot chronically lose money if you're in business trying to pay individual salaries and trying to show a profit. It's not a sustainable model. So I think the time for action in terms of economic reform, leadership from high-income countries, especially the U.S., in terms of piloting ways to try to increase and recognize the value of innovation for antimicrobial solutions broadly, I think is one of the most powerfully important gaps that we have. The reason why I'm optimistic after all of that is because of the bold talent and dedication and passion from people like the panels today. So thank you.
Maybe not specifically related to all of the presentations today, although it's relevant to most of them. To me, a big, I don't know if barrier is not the right word, but something that we don't really address, we talk about, for example, in the workforce issues that being an ID physician isn't very sexy. It's hard to describe. Antimicrobial stewardship is challenging to talk about. And for me, the fundamental issue is that it's about decision-making, and decision-making is hard to see. It's hard to talk about. It's hard to reward. And it's certainly not as interesting as orthopedic surgery or many of the other things that we talk about, for example, in veterinary training. And so I don't know what to do about it, but I've thought about this for a long time, and I think it underlies some of the issues that we have in addressing AMR is that some of the things we need to do are clearly tangible. The medicines issue is a good example. Developing new diagnostics, point of care, those kinds of things, but the people on the ground making choices, doing the education, the people that are training those that are doing those things, it's hard to explain that the most important focus is on how do you decide what to do or what not to do, and that's really challenging to explain and to get people excited about.
I wanted to talk a little bit about, it was a very sobering day today, I think, and thank you to our speakers. I'm an ID physician, adult ID physician, and on my day job, I have a large health system that I help direct in the western part of the United States. But in my passion is to really increase stewardship globally. So this has been a really great couple of days for me. And I think that we heard about some things today that it's really hard to avoid, geopolitical conflict. I don't know how we're going to avoid that. But I think putting structures into place before the disruption may be able to help curb some of the AMR side effects. This morning on NPR, I heard that there's a health system that's been cyber attacked, but somehow for the last 2 weeks, they have kept patients coming to the hospital. So there's some structures in place that can, despite things you can't control, help things continue. So I think the one thing we need to take away is how can we support building stewardship on a global level? That's really important.
I, like my colleague from Minnesota, am also an optimist and I'm a problem solver. I think that what we hear about AMR here and elsewhere is very concerning, and that we need, to do something. We do need to do a lot of things. I think with appropriate strategies and, importantly, appropriate funding, that we can do it. It's a changing environment. I mean, if when COVID arrived, we said we'd use our existing strategies to solve that wouldn't have worked. We came up with new strategies, and I think we need new strategies around AMR. I'm only going to speak on one because I know we're short of time. I really liked Dr. Barslin's pharmacoequity term, and I was trying to think of a nicer term for diagnostics, but maybe test equity for AMR. We're not in balance. I think we can do better. Others have spoken to that. I think we need better diagnostics. We need better allocation of diagnostics, and we need better implementation science for action, because diagnostics are a means to an end, but not the end itself. And I think what I heard today is we need maybe different actions in the U.S., in low and middle income countries, but importantly in refugee camps and in combat zones as well. So that's sort of two new areas to think about, separate strategies for execution with diagnostics.
All right, we're going to turn our attention to the screens. For those of you joining us in virtual land, we're going to start with Dr. Brian Lubers.
I guess I'll pay my penalty for not being able to attend in person now, going last. So I'm going to go back and I'll just share a bit of personal information. So I have a family member who's in the hospital currently, and isn't really good about advocating for their own health care. And so I'm going to go back to day one and the advocate stories. What I heard from those stories, and I would say, Mr. Purdy's, he still has some ongoing things, but in general, those were relatively positive health outcomes. It maybe have taken a long time to get there, but what I heard was a dogged persistence to advocate for yourself. I forget her name. I'm sorry. The lady that was in the car accident in South Africa, she was emailing international experts to get answers and try to come up with solutions. Is it Mrs. or Dr. Freeman? She basically refused to leave the hospital because she knew she wasn't feeling well. And I think it kind of goes to what Tim was saying about education and what Libby mentioned about patients, is that, how do we, as the medical community, we are the minority. We have a large general population that doesn't have medical training. So how do we train and empower those patients to advocate for themselves and really become stewards alongside of us? So that's what I heard out of that, and kind of the big point I took out of the 2 days, although all the sessions were fantastic.
Thank you, Dr. Lubers. I'm going to call on Michael Craig from CDC.
Thanks, all. I think the thing I would highlight is that we had 4 great sessions on awareness, workforce, companion animals, conflict, health equity. In every single one of them, there was a mention of CDC engagement or CDC activities that, in fact, facilitated some of the work or was actively engaged. The thing that I want to go back to and just underline for you all is that, the resources question is fundamental to our progress in this area. And I think, just selfishly, I would underline on the CDC side, because of the rescission of supplemental funds from COVID that was supporting a lot of the activities that you heard about today, our outlook for continuing and ongoing support for those activities that you heard about, whether it was the AR Lab Network or the work in Ukraine or other things, is in jeopardy. And so we don't know if we're going to have the sustainability for some of those activities. And over the next few years, without an influx of resources, there is probably going to be a diminishment of CDC public health activities, both domestically and globally. And I think that that's a major challenge, because we need to be heading into a growth direction and expanding our activities. And we may be faced with a reversal.
Thank you. Paige Waterman, DOD.
Hi, so I have 3 comments, one about communication, one about conflict, and the last about creativity. Again, great panels both days. So I think communication, how we tell the story matters. So whether it's talking about vaccine uptake that we heard today, or including different stories, the companion animals yesterday, and then the story about Maddie. I don't have the solution for how we require, say, companion animal vets to submit their isolates and report them, especially given the disparity in size of their practices. Although I do think the use of some vetted commercial labs could be part of the solution like we do in human health. With regard to conflict, again, the impact of AMR was important to highlight. Dump truck antibiotic delivery absolutely occurs, but I think there's still research that we could do to extend the lifespan of some of these drugs. Most importantly, however, the ecology of conflict is a driver of AMR, right? Not just a static event, is important to consider, since the environment in these settings is unfortunately the gift that kind of keeps on giving. And it's an important reminder too that for all the innovation we have for surveillance, diagnostics, drug availability, and drug use, our goals in many of these conflict and frankly under-resourced areas or settings, clean water, gowns, gloves, IPC education, are really more critically important. And last, creativity and inclusion. I think the last panel gave great examples of what to consider and how to reach minoritized populations, including their representation in clinical trials, even though it requires a better way at capturing maybe the social determinants of health and race data. Thanks.
Thank you. Jay Garland, EPA.
Yeah, you all gave a lot of really good specific suggestions. I guess what I would leave you with is just an overarching theme that I heard, and that is balance. From the very first day, from Maddie's story, I mean, my God, that young girl is such an old soul, talking about balance in her life and how that's important for her continued health. All the way to discussions from, I was really struck by Dr. Abusida talking about the disruptions in the social ecological systems that we have that can cause this cascade of events. And so really thinking about any actions we take, really framing it from the perspective of recreating balance, including whether, stop drawing lines down the middle of our communities. And I'm struck by comments that Martin Blazer gave in his last closing remarks as chair of PACCARB. And he said, he emphasized that this is fundamentally a disruption in microbial ecology. That's his perspective on the AMR issue more broadly. And I think we understand there's a complexity of issues that can cause that disruption, but it's important to really make sure that we really think about maintaining the balance in that ecology. And that's what's really going to be the long-term solution to this. Thanks.
Jay. Chelsea Shively, USDA.
Thank you. So I come to this meeting with the veterinary perspective, and I think what I heard loud and clear are that there are opportunities to do better on companion animals. We need to better understand the role that they play in the transmission and the spread of antimicrobial resistance. And I think we need to be creative about the role that the federal government can play in this space, given the current regulatory environment and the existing gaps that we have. And I think that'll be really important as we get into the work of developing the new CARB National Action Plan. So I look forward to continued conversations about how we can do better on companion animals, given our existing limitations. Thank you.
Thank you. Dr. Dixon, do you have a comment?
Just want to say everything Lynn Marks just said, and thanks to all. Good job.
Thank you, Dr. Dixon. And I'll now turn the attention to Dr. Plummer to close us out.
Well, I appreciate all of the feedback from the council members, and certainly lots of things that I could say, but in the interest of time, I'm going to try and keep them brief. I want to just reemphasize how pleased I am with the work of the council and getting the report finalized yesterday. That's a big accomplishment. The staff was hugely helpful. Thank you to them in that process. But I believe this is record turnaround time in report generation. And I feel like we have a report that really comes out with some recommendations that are helpful, hopefully, to the U.S. government. And as we enter into the UNGA discussions as well as the next National Action Plan. So thank you all for that. And with that kind of as the basis, I think the optimism I have coming out of this meeting is collaboration. And I think all of the topics that we've talked about over really all of our PACCARB meetings, but particularly this one, there's so many different components of these. And every meeting we have, we learn a new facet or a new nuance that that most of us didn't understand or didn't recognize. And so it drives home the importance to me of this council and of having these conversations, these safe spaces where we can come in, share our expertise across the professions, and really start to try and address this issue collaboratively. And so I just want to commend our speakers and all of our council members for approaching this in that collaborative effort and collaborating on the report. 12th report in 10 years. So great job to the PACCARB team in doing that, and wish you all a safe travel home. With that, I will call this meeting adjourned.
Produced by the U.S. Department of Health and Human Services.